Hello, everybody, and welcome to another edition of Health Matters, the cable access television show sponsored jointly by WCCA TV, Channel 194, and the Worcester District Medical Society. And I'm your host, Dr. Michael Hirsch, and I'm really thrilled to have with me a fantastic vascular surgeon, a topic we haven't broached very much, at least in the programs that I've been able to host. Dr. Edward Arous, who is not only a fabulous vascular surgeon, but a UMass Med and UMass Integrated Vascular Residency grad. So I have had the privilege of having some involvement in his youthful apprenticeship, and he early on displayed great proclivities in surgery. He's the son of a very well-known vascular surgeon as well, Elias Arous, and it's a great pleasure to have you here today.
Thank you very much.
Yeah.
So I appreciate it.
Yeah, it's this is kind of like watching your kids grow up when you see them come back as accomplished attendings, and you're going to be talking about a topic today that I think is very underrepresented in the pantheon of vascular disease, because people, I think, are starting to hear a lot more about how your aorta can be replaced now with endovascular devices, and people are starting to understand more now about how you have to pay attention to your walking if you're having pain in your legs, that your arteries might not be working. But the veins are the partner of the arteries, and they play a very important role in circulation. And I guess, assume, and it's true for me, assume I know nothing. And walk me through what you would tell a parent, a family, a medical student about venous disease in general. I know we're going to specifically try to talk about a very common problem. People have varicose veins, and a very serious problem that the veins develop in getting clots in them, which we call deep vein thrombosis, or DVT. But tell me what you know.
Sure. Thank you very much.
Sure.
And so as a vascular surgeon, I describe myself as a blood vessel doctor. Essentially, I operate on blood vessels throughout the body. And so as Dr. Hirsch described, arteries are sort of what people oftentimes talk about when they say I have bad circulation, but veins are just as important. And actually, vein disease is actually more prevalent than artery disease, but it's just oftentimes not diagnosed or very much underdiagnosed. So when I talk about arteries, I refer to arteries as the blood vessels. So when your heart pumps the blood out, it's through the arteries. So that travels to everywhere in your body. But veins are responsible to bring the blood back to the heart. And so arteries out, veins in. And so the problem being is that there's no pump on the vein side. So, your arteries have a heart to circulate the blood everywhere, but your veins have valves and use your muscles in your calves to sort of squeeze and propel the blood back up towards your heart. So the analogy I give is that when you walk, your calf muscles are responsible to push the blood back up towards your torso, and then your lungs help bring the blood into your heart. And so if, when you walk, the blood doesn't get all the way back with one step. You got to really be active. And so when you sit and rest, like we're just sitting in a chair, valves in your veins close, and that prevents the blood from going back down towards your foot. If the valves stop working, which can occur from a multitude of problems, multitude of issues, that's what can cause varicose veins, can put you at risk for blood clots and other things. So that's really the underlying issue.
So these varicose veins, I unfortunately have them. It's something that surgeons get quite frequently because we are standing around an operating room table, in my case, much like your dad's.
Yeah.
For over 40 years I've been doing that. And as a younger surgeon, I know everybody was very conscious of wearing thromboembolic preventive stockings to provide compression, but I stopped doing that somewhere maybe 10 years into practice. And now I pay for it with ugly legs to match the rest of me. But what's your preventative approach
Right.
to varicose veins, other than, as you mentioned, not being sedentary, sitting in a chair.
So there's a lot of risk factors for varicose veins. So some would argue actually up to 40% of the population has some element of vein disease. The most common being varicose veins or spider veins. Spider veins are sort of smaller veins we'll get into. But so varicose veins, pictured here, are really superficial veins that bulge out, because I spoke about these valves that are responsible to bring the blood back up towards your heart. If the valves don't work, then once your legs are down in a dependent position, there's more blood in the venous system. So these veins dilate, they become painful, achy, your legs become swollen, and you develop these varicose veins. Down the road, there's some risk factors of blood clots or even venous ulcers. It's not common, but it's certainly possible. So there's certainly a family history risk factor, somewhat related to occupation, patients sort of standing in, activities, if they're, a hairdresser, for example, on the feet all days, and certainly more common in women. And it's hormonal, it's related to pregnancies, oftentimes will first appear around the time of a pregnancy. But it's not to say it doesn't occur in men. I would say the majority of our patients are women because women are more likely to go and get treated. I feel like a lot of men are at home and just don't bother, or to say, you know what, I don't care enough or whatever. But so when you brought up compression stockings, the purpose of compression stockings are essentially to replace those valves. So they all have two numbers in the stockings when you buy them from, whether it's over the counter or a medical supply store, and they're intentionally tighter at the toes than they are at the top of the stocking. So they have knee-high stockings, thigh-high pantyhose, and it's creating a gradient of pressure to push the blood back up towards your heart. And so it essentially replaces the valves, and you do need to trial, usually about a 3-month trial of conservative therapy with compression stockings before you could have a treatment, usually based on insurance. But I've never seen compression stockings cure varicose veins. They just are managing them. But there's a number of things we can do nowadays. So I'm sure you've done your fair share of maybe vein strippings in the past, and so.
In the old days, yes.
So vein strippings refer to literally pulling the vein out. And so you'd make an incision in the groin, an incision in the knee, and you'd pull the problematic veins out of the body to basically, the way analogy I give is you're basically turning off the faucet. I need to stop the backwards direction of blood flow. So that's what I did when I started. That's all my training, and haven't done one of those in probably 5+ years now. Now there's a lot of catheter-based, office-based procedures. So 99% of varicose veins now are treated in the office. So it takes about 15 to 30-minute procedure, all just under local anesthesia with lidocaine, like you're at the dentist, and you put a needle in the vein and you basically close it from the inside. So the vein's still inside, but now you've turned off the faucet to cause those varicose veins to close up. So when I spoke a bit about spider veins are a little bit different. Spider veins are these really small, they're called the reticular veins, little small purpley veins. And so those are less commonly to be symptomatic, more common it's considered to be cosmetic, but we treat that with like a microneedle. So it's called sclerotherapy, where you can put a little microneedle into those veins and inject a sclerosant to cause those veins to sort of dissolve. And so cosmetically, patients are happy about that. They tend to get it done usually in the wintertime, so that their veins and legs look better for the summer and summer weather.
So, Edward, when you treat these veins and you're basically either removing them like old school or sclerosing them, meaning, kind of burning them up so that they shrivel up, what happens to all the blood that's in your leg? How does it circulate?
Yeah, so it's a great question. Most of my patients will ask that. So you have both superficial veins, which is what we're talking about for varicose veins, and deep veins. So your deep veins return about 90% of the blood back up towards your heart. Only 10% is done through the superficial veins. So realistically, you don't actually need the superficial veins. And as you know, those are the same veins that we would use for bypass surgery, if you need a heart bypass, etc. And the other explanation I give is that if you have varicose veins and you get an ultrasound to test, see which valves are problematic, those veins aren't working for you anyway. So taking out those veins does not change the return of vein circulation. It actually would benefit it because now you're not overloading the deep veins as much as you would previously. So with the various treatments, so this is an example of sort of someone who could have a vein ablation procedure. So the first test is with an ultrasound to see if those valves are working, as I described. And if the valves are non-functional, in the office, you can have a procedure to get those veins to close. After you've demonstrated symptoms and you've tried compression stockings and say, I still have symptoms despite the stockings, then most insurers would cover an ablation procedure of some type. And this patient probably had both an ablation procedure and potentially some other treatments as well to remove the burdensome veins. But again, all these procedures are just done electively. So when you brought up deep veins, so deep veins sort of shifts us over into problems that can occur in the deep veins, which are far more, potentially serious in terms of overall health effects with deep vein obstructions, deep vein thrombosis, which are DVTs.
Yeah, so let's talk about that a little bit. Maybe the audience knows that, let's say they're taking a trip from Boston to Hawaii or even further out to Australia, and they're sitting in the airplane for a long, long time. Maybe they've gotten the recommendation, you ought to get up every couple hours and walk around and stuff. Why is that? And that should lead us into the discussion of deep vein thrombosis and how it happens and what we do about it these days.
Absolutely. So it all stems back to the same issue with the valves and using a calf pump. So the purpose of getting up on the airplane or a long train ride or every hour and a half, 2 hours or so, is to get those calf muscles to circulate the vein blood back up to your heart to pump around. Just stagnant blood in your veins puts you at increased risk for a blood clot. And so similar if you'd had prior trauma, recent surgery, potentially you have a genetic predisposition to forming blood clots. If you have a family history and of various conditions that we are familiar with that put you at risk for blood clots, you really would be advisable to not only walk every hour and a half or two, but to wear compression socks on the plane. Again, to just reduce your risk of having this stagnant blood flow. So DVTs are commonly treated with blood thinners. So they get so usually patients will present with pain, swelling, or aching, most commonly in the calf. And so I think we have a picture we can show this demonstration. So usually patients will present to their PCP or will go to the emergency room with aching in that area. And it's easily diagnosed with an ultrasound, but the question becomes, how do you get the ultrasound? And so unfortunately, a lot of patients will end up in the emergency room, which is really challenging. And so this is a test that can be done in an office just the same. So if you're concerned about it, you should contact your doctor. They may put you on a brief course of blood thinners until an ultrasound can get done. And then we diagnose the test. It takes about 10-15 minutes. If you do have a blood clot, you usually would go on blood thinners for a period of 3 to 6 months, depending on the extent for the first time. If you have a second blood clot, then it becomes more of a discussion is, do you need to be on blood thinners lifelong? And so the underlying issue is that this clot tends to lodge on the valves within the veins. And so the long-term effects of DVTs are it damages those veins, so it puts you at risk for varicose veins, puts you at risk for venous insufficiency, which refers to chronic leg swelling. Chronic leg swelling, ulcers, pain, and really those effects occur years down the line, 5-10 years after an episode of a severe DVT.
So someone that has suffered DVT, we know certainly in the hospital setting, if they're on anticoagulants, that is a big risk,
Right.
Especially if you're older, maybe prone to imbalance and falling. Falling when your blood is thinned can lead to increased risk of bleeding if you knock your head, if you knock a joint. These are all places that you can bleed. So it's not something that you would want to get. And the remedy that you mentioned, frequent walking on the plane and wearing those kind of stockings, is a small price to pay to avoid it. But let's say you have it. What's the real worry that we have about these patients? DVT in and of itself, you can control the pain, you might start the blood thinners, but why is it so ominous in some cases?
Right. So the reason people end up in the emergency room and it's such an urgent evaluation is that The dreaded complication of a DVT, of a deep vein thrombosis, is a pulmonary embolism. So what that means, some pulmonary embolism, sometimes it's called a PE, where a blood clot or a portion of the blood clot from your leg embolizes, which means it breaks off and travels. So the vein blood is traveling up towards your heart. It'll travel through your heart and lodge in your lungs to cause an obstruction of the blood flow that is going to your lungs. So the blood going to your lungs has low oxygen level. It's going to the lungs to pick up oxygen. So now if you've blocked a segment of the blood flow to that lung, you might feel short of breath, you might get easily winded, you might have more severe chest pain, all because you have essentially a lower oxygen level. So the purpose of the blood thinners is really to reduce the likelihood of that sort of dreaded complication. So there's things we can do now, which is, again, newer modalities to try to reduce the risk of that. But once you have a DVT, the underlying treatment is still blood thinners. But you're totally right. What's important is to determine, is it a provoked DVT or an unprovoked DVT? So you say, I was just on a 12-hour plane ride, I'd consider that to be a provoked DVT, whereas you were just doing normal business and you don't have a reason why you got a blood clot. Those are ones that we tend to worry about a bit more, because we don't really know if there's a genetic reason that this patient had a blood clot. But so extensive DVTs now, we have treatments that we do quite regularly to basically try to suck out the blood clot. So when you brought up complications of these procedures, we first started treating blood clots, DVTs, about 20 or so years ago, where we'd put patients on basically in the hospital, in an ICU, and we would drip TPA, so it's basically a clot-busting medication, to try to dissolve the blood clot. But there was a 1% risk of stroke from that. Patients would, you're bleeding everywhere, so you have a risk of bleeding into the brain. So newer technologies have come out where now, instead of using TPA, we usually just think of it like a big vacuum or devices to try to suck out the clot. And you're really trying to decrease the burden of clot. So when you have a blood clot all throughout your left leg, you're just trying to reduce the amount. Your body creates TPA to sort of break down clot. So as long as you're creating a channel through the blood, your body will help to dissolve that clot. So again, that now has transformed from being a procedure we do in an ICU with critical care beds and monitoring to now a procedure we do in the office. So patients will similarly come in, have the procedure takes maybe about an hour to 2 hours. They're observed half an hour afterwards and they're home. And so it's crazy how things have changed just since I finished training. And so in 10 years, I've practiced so differently now than I had beforehand just because of technologies.
Yeah, the advances are astounding, really. So if you, for some reason medically, are not a good candidate for anticoagulation, let's say you have an ulcer in your stomach or a polyp that they know about in your large intestine that has a tendency to bleed anyway, they might say, no. What other things can be done to prevent embolism?
So in some scenarios, like you described, we talk about placing an IVC filter. IVC referring inferior vena cava. So the inferior vena cava filter, think of it like an umbrella that sort of sits in the IVC. So the IVC is the main vein that returns the blood up towards the heart. So your two veins in your legs sort of combine into one main vein in your abdomen, your torso, that then enters into your heart. So if someone, like you described, can't be on blood thinners and you have a diagnosed blood clot in your legs, a DVT, we can put a filter in the belly, and this is actually delivered under X-ray and ultrasound just with an IV in the groin. You end up with a little Band-Aid. So when I say it's in the belly, it's not belly surgery. But you put in this filter, and it's meant to capture large blood clots before they go to the lungs, before they embolize. So the advantage is that it protects you from large pulmonary embolisms, but really doesn't prevent you from forming other blood clots. So we consider this to be a second-line treatment, so only for certain scenarios. So before we'd put these in and it would be permanent in everybody. Everyone have a IVC filter would stay there forever. And now most or all IVC filters are now meant to be retrievable. So if you're 20-something-year-old in a car accident and had a broken leg and you have a blood clot, you can't be on blood thinners because you're going to have leg surgery. We'd put in a retrievable filter. So it stays in for, the FDA recommends 1 to 2 months. And then they recover from their surgery, they're able to go on blood thinners, and then we retrieve the filter. Again, all done out of the hospital.
Now, tell me about this newer procedure. Well, it's newer to me. It's probably old hat to you. That is also done in radiology with the cardiologists. The Watchman.
Watchman.
Yeah.
Yeah. So it's more meant. So Watchman is meant for atrial fibrillation, and so for patients who have atrial fibrillation refers to so you have different chambers of your heart that pump as your atria and your ventricle. So your atria, instead of pumping, it fibrillates, meaning it just sort of is more stagnant. So you're prone to get clots in that area because it's stagnant blood flow. So the concern with atrial fibrillation is a risk of stroke. So this is different. This is on the artery side. So those patients get put on blood thinners to reduce your risk of stroke. But if you're a person that's at high risk for blood thinners, falls, etc., you put a device to block that segment of the atrium. So the clot would sort of stay there, has no longer an embolic potential. So that's something to discuss with your cardiologist, see whether you're a candidate for that if you have atrial fibrillation and on blood thinners and want to get off. But I'd say it's different than IVC filter and DVTs, very different, but
Yeah.
similar, done percutaneously with IVs in the groins, done by an interventional cardiologist, sometimes a radiologist, I would imagine, but pretty straightforward.
So, I mean, we've gone through quite a bit of venous and vascular innovations. I can tell you, if I knew what I know now, back when I was a young intern, like when I first met you, I would definitely have worn my stockings more. But I think overall, what is there anything else that an average patient can do to reduce the likelihood of venous disease?
So staying as active as you can be. So not just, exercise, walking, weight plays a role as well. So venous disease is more prevalent in patients that have obesity as well. Wearing your compression stockings. So you're totally right. In training, most of the residents wore compression socks. You're in the OR operating for 12 hours a day, every day. You're not really moving around. So important to sort of gauge that. If you have a family history of varicose veins, your parents, mother, siblings, your elevated risk, and then someone if you have a family member that has a history of blood clots, bring that up with your PCP. Perhaps you should be wearing compression stockings. Perhaps there's some genetic tests that can be done to determine whether you are at elevated risk for that. But really preventative, I totally agree with you. Preventative measures can save you bounds of procedures down the road. So very much advisable to try them, as uncomfortable as they are, to get some compression socks.
So Edward, when you set up your office, you have a procedure room that you do a lot of these procedures in?
We do. So we have an X-ray suite where patients will come in, and under X-ray we'll put stents in the legs, or we'll suck out those blood clots like we sort of described for DVTs, or replace those IVC filters. And that's all done with critical care nurses, radiation technologists to man our X-ray. And then we have a separate procedural area for all of our superficial vein treatments for varicose veins, sclerotherapy, and the full vascular lab. So all these patients don't just come in off the street and say, I need to have a blood clot sucked out. They all get consultation and evaluation with ultrasound. So we have a whole slew of registered vascular technologists, so basically ultrasonographers, to diagnose you. And so if you come in with varicose veins, it's important for me to know which vein is really the underlying issue. It's usually not the one that's sticking out. There's a feeder vein deep to that I need to address. So our technologists can help guide the providers to figure out what really needs to get done.
It's really astounding. I mean, I don't think you remember, maybe you, as a youth, your dad watched this movie. There was a movie called Fantastic Voyage, which featured Raquel Welch and a couple other very good stars, and they miniaturized themselves in a little submarine to go through the circulatory system to get to a blood clot in the scientist they were trying to save's brain. And we're not far from that. I don't know about the miniaturization, but the instrumentation you're talking about is very
It's
small.
totally different. So I mean, people are amazed that everything's done essentially with a Band-Aid. And so just like the IV that the nurse puts in your arm for the procedure is the same size that we treat your veins or we put the stent in your leg. All that's done pertains to patients are home within an hour. So you come in, you might have to lay flat for half an hour, and then you're out the door. And so, as you said, so I grew up in Worcester. I'm from Worcester, went to school here, med school at UMass, and did my training there. And things have changed leaps and bounds since I graduated, or even since I started my training. And I mean, I'm young. It's fun to be able to sort of be young enough to latch on to technology as it goes on and really be sort of at the forefront of, new technologies that are coming out. So clinical trials and things that we really have available to us now. So I appreciate it.
Well, I think, Eddie, it's been great to have you on board, and I think, this is a very common problem. I don't think it's necessarily talked about a lot because, people are embarrassed, their legs look weird or ugly in their minds, and it's great to know that there are great resources out there that we can rely on to get them feeling better about their cosmetic appearance and also potentially prevent them from getting something really more serious like a DVT or a pulmonary embolus. So I hope that the audience agrees that this has been very instructive, and I appreciate your time. And we, on Health Matters, we've covered the waterfront on just about every topic, but when I was looking back on old shows, this one somehow had escaped. So I'm glad that we were able to get you here tonight, and thanks for the information.
I appreciate it very much.
Best of luck.
Thank you.